This is a Davies award-winning use case for the value of health IP. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health IT to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and IT-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information technology to improve patient outcomes and value. The Davies Award's winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health IT-enabled care delivery. It is my pleasure to welcome our speaker for today's webinar, Dr. Coate, and I will turn it over to Dr. Coate and let him give a brief introduction, and then we will go into the presentation.
Ramesh Coate. I'm Vice Chairman of Cardiology at Cleveland Clinic. I'll be talking today about our work in developing a heart failure checklist, but more importantly, a lot of foundational work from an information technology standpoint and a journey that took us over almost 5 years of discovery in terms of what we did to do this. Thank you for this opportunity to speak today on behalf of Cleveland Clinic and its Heart and Vascular Institute. I'll be speaking today on creating value from electronic medical records, the story of the heart failure checklist. For context, this is the picture of the Heart and Vascular Institute. This is the Miller Pavilion. This is the main entrance for the Cleveland Clinic in Cleveland, Ohio. The Heart and Vascular Institute is basically a hospital within the hospital, and it has a very storied reputation. It's been ranked #1 for heart and vascular care for 23 years, over 500,000 outpatient visits, 13,000 patient admissions, 422 dedicated heart and vascular inpatient beds, and 180 staff physicians. In spite of this great performance that we had some serious issues from an information technology standpoint, and this story here actually starts a number of years back in 2011. And at that time, we were asking a question about how do we identify the correct attending and correct service, and from the patient's perspective, really simply, who is my doctor when I'm in the hospital? And as we looked at that, we actually had what's called a legacy system at that time called the ADTR system, where this information was housed. And this was a front-end system that then drove information into Epic. So this ADTR system was actually the source of truth for Epic. And as we looked into this deeply, we found out that this is where the information was held, and we found some mismatches here. So we have a listing of doctors here, and the services that they were assigned to sometimes were misspelled. For example, here under catheterization is misspelled. Other times you have doctors such as Dr. Mark Gillenoff, who's the chairman of cardiothoracic surgery, listed as a thoracic surgeon. You have Dr. Niebauer, who's an electrophysiologist, listed as clinical cardiology. So there are already some information gaps here in terms of correct information that was found in this ADTR system that led to some questions and concerns. But what we noticed is that this information was then linked directly to Epic via an interface. So not only was this information important for this legacy system, but it was also important for ultimately driving the clinical care process in Epic. So here, for example, here is a patient where ADTR and Epic list the attending provider as Dr. Cho and the service as clinical cardiology. But when you look at it from the patient's perspective, the patient is actually being taken care of by Dr. Griffin, and the patient is actually on the imaging service. And so we see this gap here, and our initial thought was this maybe was an isolated issue, not something that was happening very commonly, but we thought we had to test it given how important it was to our clinical care. Why is this really important? It's important for a lot of patient care issues. We noted that patients were being admitted to hear the electrophysiology service. The wrong attending and service were identified in Epic. Nursing couldn't reach the attending or service, and the patient sat on the floor for 8 hours without being seen, and the patient ultimately had complete heart block and had to have an urgent procedure. We also had some patient safety issues, or a patient with end-stage aortic stenosis was on the imaging service. He had been made DNR by the primary team, but he became unstable, and then there was a contacted the service that was listed, they actually initiated a code, and then the actual team had to arrive and stop the code once that information was correctly found. This actually was quite common. Our chief fellow pager at that time was collecting information, and there was a lot of information about inability to find correct information clinically that led to problems with clinical care. And so this was something that was not isolated to 1 or 2 patients. This was something very common and something very important. So then we said, let's test this and understand this. So we actually did an attribution methodology, and we looked at October 5th, 2011. We asked a question, does Epic identify the correct attending in HVI? And the answer was that 45% of the time, yes, 45% of the time, no, and 10% of the time it was difficult to identify what the correct attending was. We also asked the same question for the service, and this was actually even worse. Only 22% of the time was it correct, and 78% of the time it was not correct. So there are very serious problems with the accuracy of this information in the underlying clinical health record. We then took that broader and looked at the entire Cleveland Clinic main campus and did a similar test here to see whether this information was correct or not. So here across main campus, this is almost 1,000 patients, 55% yes, 36% no, 9% could not be identified accurately. And then here on the service, 30% yes, 61% no, 9% could not be identified. So this pattern that we saw in heart and vascular was also similarly seen across the entire main campus. This impact is not just for the clinical care of the patient. Because electronic health records then drive all kinds of different reporting aspects of the organization, whether it's clinical care, whether it's patient experience, length of stay, quality, readmissions reports. There's about 45,000 electronic messages a day that are pinging this attending physician information. And all this information, if this is inaccurate at the baseline, is then inaccurate in all of the subsequent reporting. So this is a very serious problem that got to the heart of our clinical operations and really needed to be addressed. So what we created here was an Epic banner or header where we clearly identified the attending physician and service very prominently in Epic at the point of care, so it could be seen by all people taking care of the patient and could be adjusted in real time. This actually, although seemingly simple, took almost a year in terms of making the case for change, initiating the project, creating the technical build from the Epic standpoint, creating rules of engagement, and then having a final HVI announcement from this perspective. We also had to come up with standard operating procedures to describe how the clinicians, including the nurses, the nurse practitioners, the house staff, and staff would interface with this information and work on it from a clinical standpoint. Because this is so important, I'm going to show you a video here of 2 of our senior physician leaders, Dr. Nissen, the chairman of surgery, and Dr. Lytle, who is the chairman of Heart and Vascular Institute, where we made a video to actually speak to our frontline caregivers about how important this information was and why it was important to work on this new program. I'll transition now to this video.
This one, do you have the CVICU edited problem?
December the 4th is the go-live date for a new program in which the attending of record will appear in the Epic banner. This is an extremely important new program for the Heart and Vascular Institute.
If that banner identifies you as the responsible physician, you are, and I am.
When we get new admits on the floor, half the time we can't figure out who we're going to get our orders, who needs to come see the patient, and that's a big concern, especially if it takes more than an hour for someone to come and assess the patient, decide what orders need to be placed and what we need to do to care for the patient.
For me, I think I know who I'm supposed to be taking care of, but for others who have to get a hold of me, there are a lot of misconnections, delayed communication. And I think this change should make a big difference.
We don't want to page somebody in the middle of the night, but if it's necessary, we want to make sure that we're getting the right person. Especially because in the middle of the night, we're not going to page for something that's not important. We want to make sure that we're getting the right person the first time around so that that important issue is being addressed right away.
It is a change. We expect that there be some mistakes, but we certainly expect to be able to do better than the 60% accuracy rate of our current system.
You sort of figure out ways to try to figure out by who wrote the last note or who put in the last order, but even as a cardiology fellow, I figured out I could barely figure out which of my cardiology colleagues were taking care of some of these patients.
So with this new process, being able to see the physician in the corner of Epic, you will ultimately eliminate that and eliminate the fear of paging the wrong person or paging somebody that's not on call or that isn't here.
This is, I believe, a step forward into the future. I think it'll make things more accurate, and we ask for your support and cooperation. Thanks very much.
So as you can see, the organization took this very seriously, and it showed, in fact, in terms of the project impact. Within 6 days of going live with the project, our accuracy for the attending physician had increased from 45% to 94%, and our service accuracy had increased from 22% to 73%, which shows how seriously both the frontline and leadership took this project. When we look at it from a long-term sustainability standpoint, we also looked at the information as we went out in time, and in fact, it got better with time. As we followed it out in terms of looking out 30 days and 180 days, overall accuracy exceeded 90%, and this program has now been in place for almost 5 years at the Heart and Vascular Institute. The next thing we wanted to do is how do we identify diagnosis? What conditions do our patients have? And we used a technology called Problem List, which is a way to have discrete ICD-9 and now ICD-10 problems listed within the patient's Epic chart. It allows standardized and structured diagnosis so that we can find here, for example, a patient with heart failure. Rather than searching the chart manually or electronically, we can find a discrete diagnosis for this. So our problem list utilization started here in 2009, and it's been continued. This is our audit through 2013. We've had over 90% problem list utilization, and this continues to this day on in Heart and Vascular. The next thing we wanted to say is now we have this information, is how do we feed back information about quality to physicians? We audited our process in 2011, and it actually took almost 4 months for there to be any type of feedback to our physicians about clinical quality. This was in the case of CMS core measures. By that time, there was really nothing the physicians could do to impact that, and so we needed to move this earlier into the time process. So we came up with a process called real-time quality feedback. We called it core measure yellow triangle. I'll show you what that means here in a second. But it basically integrates the problem list, the Epic banner, and structured documentation. So here, for example, is a sample screen in Epic where we can now see the patient's service. We can see who the attending physician is. We can see important quality measures. We can find out if the patient has heart failure or myocardial infarction. And you can see here these yellow triangles are gaps where there are needs to either document or correct information or prescribe medications to close these gaps. And this information is available in real time, updated to the minute in Epic at any moment. So what physicians can then do with the yellow triangle, they can either prescribe the medication, they can put an allergy or contraindication, they can put a temporary contraindication order, or sometimes they can wait if there's some clinical reasons to decide later in the hospitalization. So we took this information and we found that by doing this and providing transparency to quality, we saw a significant and sustained improvement in our quality measures from the standpoint of myocardial infarction and heart failure. And when we compared ourselves to other parts of the organization that were not using this, our performance was sustained and improved over time. This actually led to very important improvements in our public reporting. And so here you see our public reporting information. Starting in 2013 and 2014, we had near 100% performance improvement. The numbers in 2015, some of these measures actually started to go away, but we were actually very happy with our performance from that standpoint. The next thing we wanted to answer is that when is the patient scheduled for follow-up after hospital discharge? And we had developed a program to have follow-up appointment scheduling, and we decided that this really should happen at admission. And our goal was to ensure that all patients were discharged with a scheduled appointment. So to do that, we created a follow-up appointment order in Epic, which designated the reason for follow-up, when the follow-up should happen, who the follow-up is with, also to have an early follow-up with a nurse practitioner or physician assistant, and then also a feedback loop to the ordering individual with their pager or phone number. And the way this practically happens, this order gets placed, it gets sent to a scheduling pool. That scheduling pool acts upon it, finds the order, and finds the appropriate appointment, and then text pages back. This actually happens typically during business days with a feedback loop of a couple hours. So this can actually happen quite quickly. and therefore then the patient leaves now with an appointment clearly designated on their discharge summary prior to the time they leave the hospital. This order has been used quite extensively, and we are typically running anywhere from 500 to 700 patients who are using this order in the Heart and Vascular Institute. This is now being moved across the entire Cleveland Clinic as part of an enterprise project. So we had these foundational initiatives where we put together the EPIC banner and header for the attending service. We had accurate data attribution. We had problem lists to find our patients with particular diagnoses. We had structured documentation, and we also had a follow-up appointment order. So these were some of the key foundational initiatives that were necessary for us to then move into the next part of our program. So here clearly as we start is that we have our foundation as we described. We then moved into another problem, and we started focusing on readmissions because this was something that was getting increasing attention from Centers for Medicare. And from the organization standpoint, it was named the highest enterprise priority because there were a number of projects that attempted to improve this but hadn't made much impact. And we actually have been penalized quite substantially from CMS. And so the Heart and Vascular Institute was requested to take greater involvement and leadership. And we proposed a discharge checklist. The reason why we proposed that came from some data that we were looking at in myocardial infarction. And we found that the risk of readmission was very front-loaded. So the risk of readmission for a patient was happening very early after hospitalization. And if you look at here more specifically, if you were looking at cardiovascular reasons for readmission, which we would think are the most modifiable, those are happening very early, typically within the first 15 days. So our hypothesis was that preventable readmissions occurred early. We actually had some data saying that the more outpatient follow-up you had, the actual more admissions, so we didn't think that would solve the problem. We had done some project with discharge follow-up phone calls. That had no impact. We had done some projects with telemonitoring, no impact. And so we hypothesized that the defect in terms of what could impact modifiable readmissions was in the hospital or at the transition and discharge. So we proposed a discharge checklist and then some in-hospital care metrics to monitor that. So we started off with a pilot study where we took together a unit that's dedicated to heart failure called J72, and we put together this paper checklist which brought together information from nursing, multidisciplinary consults from other areas such as nutrition, pharmacy, also had physician and nursing feedback, and all of this information was then put together in one place in a way that could be tracked from a paper standpoint. So we decided to put a quality improvement study where we looked at two services on heart failure A and B, which are dedicated to heart failure care. We sort of followed them for 12 weeks, and we did intention to treat. Intention to treat basically means that if you're assigned to the checklist, you're assigned to the checklist whether it's filled out correctly or not. And then we also had concurrent and historical controls. And to our great happiness and surprise, this actually had a dramatic reduction in readmissions. Here, for example, the legacy rate of readmissions was running about 25%. And for those people on the checklist in this unit, their readmission rate was 14.6%. And so this is one of the lowest levels of readmission we had seen, and it actually grabbed our attention quite seriously. We were also following this. In fact, at one point we stopped the checklist because we were not sure if we were going to be able to scale it across the organization. And when we stopped it, the readmission rate went up dramatically, and then when we restarted it, it went back down. So we really thought we were onto something in terms of this checklist being an important part of our goal to reduce readmissions. One of the challenges with the paper checklist is that obviously it was paper, it was very manually intensive, it was very difficult to have any reporting based upon it, and given the size of our organization, the chances of scaling it to other areas was very difficult. So we had sort of proven our concept, but we were at a difficult point where we needed to be able to scale this to a larger part of the organization, and the paper really was not going to be doing it properly for us. So we wanted to transition from paper to electronic, and it turns out that it seems simple, but it's not so simple. On the paper side of the workflow, it's fairly linear and very simple. You show the paper checklist is in the room, the checklist is updated in the room, and then it's displayed in the room. And it's all very centralized, and everybody works around the patient in the room. When you look at it from the standpoint of the workflow for electronic checklists, it's actually much more complex. And there's a number of different parts here that have to be put together. So we started mapping this from this standpoint. And we also started mapping how we would do some appointments if we wanted to put this together in a synergized way. And it turns out to be much more complex when you try moving to electronic workflow. So here, as we started planning and designing that more specifically, we wanted to look at each of the different areas and how they worked. So what we did is we first created a governance structure for the electronic checklist. We created funding for the project. We then identified the key roles on the checklist and where the documentation will be. And then we defined how the electronic documentation workflow would work together all in one area and ultimately to come together. So this was our governance structure here. You had the clinical executive team from the Cleveland Clinic sponsoring the project. You also had clinical leadership here. And then we had multidisciplinary working team from all these different areas: nursing, quality, information technology, nutrition, pharmacy, care management, all working together. So here, for example, is what the nurses are doing here on the paper side in terms of the different activities that they're doing from an education standpoint. And so here, for each role, we had to identify who is documenting this, where is the work being completed in the EMR as opposed to paper, and what work activity in the EMR would satisfy the same thing that would be checked off on paper here. So here, for example, is how nursing would look as the paper is on the left, and when you look at it on the right side, there is areas within the electronic workflow where this information is grabbed from that standpoint. Here, similarly, is pharmacy from that standpoint, is you have paper workflow on the far left, and then you have a discrete note where the pharmacy information is being captured from that standpoint. Here's care management on paper, and then there's a discrete area within the checklist electronically where care management will work. And then here also is physician documentation, clinical information about the patient, documented in paper, and then also discretely documented in the electronic workflow. So what we were trying to do here was to bring together electronic unified documentation where you had multidisciplinary, multi-user, physician, nursing, nutrition, pharmacy, care management, all in one place with updates that were occurring immediately at the point of care. And so here, for example, is all the electronic workflow that's all in different areas being worked on at different times and in different places. But we needed to bring this all together so that we have all this documentation in one place. And this really led us to develop this congestive heart failure discharge checklist here. And so this information then brings together all the different aspects of the care process: nursing, nutrition, pharmacy, care management, and it also then brings back the physician side. So this is all of this into one place, gathering all these information from these different electronic sources. So we now were able to prove an electronic multidisciplinary checklist, which could then have an electronic workflow to support it. One of the next challenges we found is that the reality is that most patients who are admitted to the hospital don't have heart failure, so how do we find those people? So we created what's called a multi-level inclusion criteria, where we would find the services that we were interested in, we would find the units that we were interested in, and we'd find out if they had a problemless diagnosis of heart failure. So we could scan the electronic medical record for this information since we had it foundationally. We also could exclude patients with observation status who we were not interested in because they were typically in for other reasons. And so here, for example, showing the complexity of our organization, this is a sample. We have 21 inpatient units, 22 services. We have thousands of diagnoses, and we might have 344 patients at a time. And we want to find out only these units on these cardiology service with this diagnosis and exclude the patient with observation status. And so what this can do is then find those 62 patients who meet those criteria and exclude all the other patients. If you imagine doing this by paper, this would almost be impossible. You'd have to scan this not electronically, by hand, reading all these different charts to find out what this is. This can be done typically in seconds and can be done at any time, repeatedly as the census changes, and it can be done very rapidly. So we now had multi-level inclusion to find our patients. We then also wanted to have a feedback loop so that our clinicians could know whether the checklist was filled out or not. And so we had this real-time checklist visualization. If it was completed, there was a green checkbox. If it was not completed, there was a stop sign. So this information could tell whether the checklist was done or not. We also were able to hover over this, and if you hover over the red stop sign, it'll tell you what parts of the checklist are not completed. So there was clearly real-time feedback at the point of care for the clinicians immediately to be able to assess what has been done and what's not been done. We also wanted to ensure compliance with this, so we started off with an electronic soft stop, and then we moved into a hard stop. What that means here practically is that if a patient is to be discharged, initially there was a soft stop, and it would say here, one or more tasks require completion before the patient can be discharged. Please review the checklist and make sure you're in the correct login. But you could bypass this, and so you could bypass this. But over time, actually, after a few months of this, we actually went to a hard stop, and this hard stop has now been in place for multiple years. One or more tasks require completion before this patient can be discharged. Please review the checklist for incomplete data. These orders cannot be signed. And so the patient's process stops. And what that forces the care team to do is to really be cognizant of this information and get it done before the patient is to be discharged. So we now had an electronic soft and then hard stop to ensure compliance with this information and this care process. This, again, takes a significant amount of effort and time. And so here, when we put our governance presentation in September 11th, we then had to put a case for change in January 10th, initiated the project in February 25th, built it in April, pilot initiation in J72, and then we fully went live across heart and vascular in November. So again, more than 1 year of development time to put this together because of its complexity. And so we basically had transitioned from a paper to electronic checklist, and we felt quite successful about that. But then there's obviously some challenges, and so we now face the challenge of actually getting this to work on the front line, not just the electronic side, but the actual clinical workflow. So we had this great idea of taking paper, moving it electronic, and then we hit reality. And the reality is that you can't anticipate exactly what the frontline care issues are until you actually do them. And so that's some of the feedback that we got. So one of the things that we heard back was we actually assumed that the frontline was aware of the need of the checklist, the importance of reducing readmissions. It turns out they weren't. Despite the fact that this was very important, many people did not know about this, and so we needed to educate them. There also were some staffing issues from that standpoint. There were some Epic login issues. We also had some scheduling issues about how to schedule patients. So we had to address these issues. Another thing we found out is we were very focused on the technology and less on the human factor side. And so there became some concern from our end that people were checking boxes rather than delivering care. There was initial explosion use of the checklist on patients who did not need it. There was some concern about checklist avoidance and possibly changing diagnoses. And then there was some concern about what we call sort of adversarial behavior, about refusing to do it. And so here, for an example, here is an order that was put in where at the top of the order it says here, appointments already requested, no request needed, patient is not in heart failure, this order is to appease Dr. Code. So there was some feedback here from the front line about our need to really get them involved in terms of the why of why we're doing this. So we took a step back and we created this infographic where we really tried to explain to the frontline clinicians, why are we doing the heart failure checklist, who gets the checklist, what is a heart failure checklist, and we really went to the basics and didn't assume anything in terms of their knowledge. And so here, for example, we would say, why is a heart failure checklist? We gave the supporting data to show that it's had an impact in terms of reducing readmissions, to convince them that this was important. We'd ask who gets the checklist, we'd have the headline, and then we'd show in terms of how this information was being tracked in the electronic record and how you could then hover over to find out compliance with it. We'd also talk about what is it, and it really is ultimately a way of bringing all of these different aspects of the organization together: nutrition, pharmacy, care management, the physician, nurse practitioner side, physician assistant side, nursing, all under one umbrella to work together for the care of the patient. And so we then started communicating this in terms of the go live formally to support the clinical rollout and to ensure that the frontline really understood what they were doing in terms of supporting the checklist. So one of the communication things we wanted to do is that this really is there to ensure care coordination across all the different specialties. It's something that really should start at admission and that we don't want to wait until discharge to complete. It ensured discharge readiness for the patient, and it was just part of the normal clinical care for that. Another technical aspect that we had is that we needed to educate a number of people, and given our volume, doing this was actually very difficult with our existing workflow. So it was very inefficient and impossible to have 60 individual classes for all of these patients who were admitted with heart failure. And so as we thought about scaling this, this was going to be quite a challenge. And one of the challenges practically about trying to get a class scheduled is that patients with heart failure are typically admitted, and there really is no method at that time to schedule what would be an appointment or an outpatient visit or a class from within EPIC at that time. So we wanted to create an education order that would then be routed to a secretary for scheduling. We wanted to be able to measure our electronic reporting of this class, and we basically wanted to be able to schedule a clinic visit for an admitted patient, which was actually quite novel and had not been done in our organization in any other area. And so here, for example, is the order where this information would be put together, and then this would then go to the secretary, similar to our follow-up appointment order, and then the patient would be placed in a schedule for a class. This would allow us to scale up the number of patients who would be seen, and instead of having one-on-one efforts, we would now have 10 patients together where the team could then educate them as a group. The feedback from this class was extremely positive, and here are some examples. I really liked the overall presentation being so relaxed. It pertained to my everyday life, was very relevant. Some admissions, I was really bad about how much salt I ate before going to this class. I found that since I don't use as much salt, I've gotten used to it and started other things with their food. Nurse had really good menus. I picked up the American Heart Association book that they recommended and helped me with managing my heart failure, and it gave me good information on how to live with heart failure. So this education, there was very positive feedback from all of the information that was provided, and I think for the patients there also was a positive sense of community, that they were not alone with this problem and that many other people were also dealing with the same issues. So we now had really addressed the clinical reality in terms of how we would get this to work in the front line. Just from the standpoint of context, when we looked at the total cost of putting this together in terms of that, the cost of this was about $200,000. And we'll show you here in a moment some return on investment information to show its impact. So how do we then measure the performance management and reporting of this information to see if it had an impact? So one of our challenges was how do we display this performance data in a meaningful way? How do we bring it all together in one report? And how do we scale it over both the size of our organization and also measure this over time? And so we actually created a new reporting and visualization tool using a software called Tableau. This was flexible and easy to use. It allowed customization of views and criteria, and it would align us with the activity that was completed in electronic medical record. So here, for example, is a documentation electronic medical record, and here is how we pull this information into a Tableau report to allow us to measure compliance for all of the different performance indicators here. So here, for example, you can see on the left is the provider compliance in the electronic medical record, and then you can see the provider compliance aggregated across multiple patients on the right side in the Tableau report. And the same thing here, you can see different performances across different areas, and then you can also drill down to individual patient detail if you want to find out a gap and understand what is happening. So this information allowed us to really report much more accurately and feedback this information to the team that was managing the project. So what are some of the impacts we saw from this? I'll first show some short-term, and then I'll show some long-term. So here's short-term in terms of the scaling of the checklist. Just in the initial 6 months of full scaling, over 1,500 patients were being monitored and put through the checklist. And so this clearly had scaled up from the small numbers of patients we were doing from a paper standpoint. When we looked at compliance of paper versus electronic, the electronic checklist compliance was much higher than we saw. The one gap we saw on the provider side was the fact that there was a login context issue, which made it difficult to close a compliance gap. But overall, the compliance was much higher with electronic versus paper. When we looked at the readmission rate, we had an enterprise target of achieving a 20% readmission rate compared to our typical range of about 25%. And for the first time ever, we were able to actually meet that target. So this is actually the first project that had been able to actually achieve that readmission reduction of any of the initiatives that we had done. One of the interesting things we noted is that when we first tried to roll it out, there actually were some hiccups. And you can see here at the beginning, when the electronic checklist was deployed, there were some jumps in terms of the readmission rate. But the team persisted and really tried to initiate and make sure the checklist was driven down to the front line. And when it was fully implemented, you can see the reduction readmission rate that was similar to what was being seen on the paper side. What are some long-term impacts here? Here it looks at long-term impact over years. This looks at our legacy from 2012. We started a paper checklist in 2013. In 2014, we started the electronic build, and then we started fully deploying that. And we've seen now almost 3 years of sustained reductions in readmissions associated with the use of this checklist in our organization. One of the important things that we look at is that there's actually penalties from CMS, and so these are some of the ways in which CMS measures what's called excess hospital readmission ratio. And for the first time, also with the checklist, we started seeing reductions in that readmission ratio, which ultimately impacts the penalties that we are required to pay by CMS. And if you look here, we've actually calculated the penalty reduction associated with the heart failure checklist, and it was over $300,000 reduction in penalty that we've seen by putting this checklist in place. So in comparison to the cost, we saw a significant return on investment just from the fact of the penalty reduction from the CMS programs. This program was an extremely multidisciplinary program involving caregivers from all parts of our organization, and these are the team members which I'd like to recognize for their commitment and dedication to this important project. So to summarize the technologies that are the foundation of this, there really were 10 of them. We created this patient banner or header to have the attending and service clearly indicated. We had problem lists to have discrete diagnosis to find patients with the particular diagnosis of interest. We had real-time quality metrics to feedback quality in real time. We brought multidisciplinary documentation to put together nursing, physician, care management, pharmacy, nutrition all in one place. We had multi-level inclusion criteria so we could find patients in real time with heart failure so we can act upon them while they're in the hospital. We had follow-up appointment orders so that we could correctly assign patients to appropriate follow-up at the time of discharge. We had electronic order hard stop. We had shared medical appointments. We had Tableau reporting. And we also had hover over, which is a feedback loop so that clinicians could find the correct information that needed to be fixed on their checklist. And these really turned out to be the foundational tools that allowed us to be successful in terms of delivering this project for the benefit of our patients. So in summary, this heart failure checklist really was a technical and operational success with 100% implementation across Heart and Vascular Institute that's now been in place for many years. One of our important lessons we learned is that we underappreciated the importance of the human and technology interface, and that's something that we're much more cognizant now of after working with this project. This project ultimately reflects a true multidisciplinary coordination of care while the patient's in the hospital, and we've seen significant decreases in our readmissions locally and also in public reporting with a significant return on investment for this project. And so in summary, I'd just like to thank everyone on the team for their commitment to this project, and I believe we've been able to show how we take important foundational information technology steps and then drive them all the way down to the front line for the benefit of our patients and for ultimately to improve the clinical care that they receive. Thank you very much.
Great presentation. Thank you, Dr. Cope, for that great presentation. Just want to give folks information on how to find more Davies use case information and Davies use case webinars and information on how to apply for Davies Award that could be found posted at the HIMSS Davies Award website at hims.org/Davies. And thank you so much. Have a good day.